Modes of mechanical ventilation. Modes of mechanical ventilation are one of the most important aspects of the usage of mechanical ventilation. The mode refers to the method of inspiratory support. In general, mode selection is based on clinician familiarity and institutional preferences, since there is a paucity of evidence indicating that the mode affects clinical outcome. The most frequently used forms of volume-limited mechanical ventilation are intermittent mandatory ventilation (IMV) and continuous mandatory ventilation (CMV). There have been substantial changes in the nomenclature of mechanical ventilation over the years. More recently, it has become standardized by many respirology and pulmonology groups. Writing a mode is most proper in all capital letters with a dash between the control variable and the strategy, i.e. PC-IMV or VC-MMV, etc. Taxonomy for mechanical ventilation. The taxonomy is a logical classification system based on 10 maxims of ventilator design. 10 maxims. A breath is one cycle of positive flow inspiration and negative flow expiration defined in terms of the flow time curve. Inspiratory time is defined as the period from the start of positive flow to the start of negative flow. Expiratory time is defined as the period from the start of expiratory flow to the start of inspiratory flow. The flow time curve is the basis for many variables related to ventilator settings. A breath is assisted if the ventilator does work on the patient. An assisted breath is one for which the ventilator does some portion of the work of breathing. For constant flow inflation, work is defined as inspiratory pressure multiplied by tidal volume. Therefore, an assisted breath is identified as a breath for which airway pressure displayed on the ventilator rises above baseline during inspiration. An unassisted breath is one for which the ventilator simply provides the inspiratory flow demanded by the patient and pressure stays constant throughout the breath. A ventilator assists breathing using either pressure control or volume control based on the equation of motion for the respiratory system. Providing assistance means doing work on the patient, which is accomplished by controlling either pressure or volume. A simple mathematical model describing this fact is known as the equation of motion for the passive respiratory system. Pressure equals elastance x volume plus resistance x flow. In this equation, pressure, volume, and flow are all continuous functions of time. Pressure is actually a pressure difference across the system, e.g., transrespiratory pressure defined as pressure at the airway opening minus pressure on the body surface. Elastance defined as the change in pressure divided by the associated change in volume. The reciprocal of compliance and resistance defined as a change in pressure divided by the associated change in flow are parameters assumed to remain constant during a breath. Volume control VC means that both volume and flow are preset prior to inspiration. In other words, the right-hand side of the equation of motion remains constant while pressure changes with changes in elastance and resistance. Pressure control PC means that inspiratory pressure is preset as either a constant value or it is proportional to the patient's inspiratory effort. In other words, the left-hand side of the equation of motion remains constant while volume and flow change with changes in elastance and resistance. Time control TC means that, in some rare situations, none of the main variables pressure, volume, or flow are preset. In this case, only the inspiratory and expiratory times are preset. Breaths are classified by the criteria that trigger start and cycle stop inspiration. The start of inspiration is called the trigger event. The end of inspiration is called the cycle event. Trigger and cycle events can be initiated by the patient or the machine. Inspiration can be patient-triggered or patient-cycled by a signal representing inspiratory effort. Inspiration may also be machine-triggered or machine-cycled by preset ventilator thresholds. Patient triggering means starting inspiration based on a patient signal independent of a machine trigger signal. Machine triggering means starting inspiratory flow based on a signal from the ventilator, independent of a patient trigger signal. Patient cycling means ending inspiratory time based on signals representing the patient-determined components of the equation of motion, i.e. elastance or resistance, and including effects due to inspiratory effort. Flow cycling is a form of patient cycling because the rate of flow decay to the cycle threshold is determined by patient mechanics. Machine cycling means ending inspiratory time independent of signals representing the patient-determined components of the equation of motion. Breaths are classified as spontaneous or mandatory based on both the trigger and cycle events. A spontaneous breath is a breath for which the patient both triggers and cycles the breath. Spontaneous breath may occur during a mandatory breath, e.g. airway pressure release ventilation. Spontaneous breath may be assisted or unassisted. Mandatory breath is a breath for which the machine triggers and or cycles the breath. Mandatory breath can occur during a spontaneous breath, e.g. high-frequency jet ventilation. Mandatory breath is, by definition, assisted. There are three breath sequences: continuous mandatory ventilation (CMV), intermittent mandatory ventilation (IMV), and continuous spontaneous ventilation (CSV). A breath sequence is a particular pattern of spontaneous and or mandatory breaths. The three possible breath sequences are continuous mandatory ventilation (CMV). Spontaneous breaths are not allowed between mandatory breaths. Intermittent mandatory ventilation (IMV). Spontaneous breaths may occur between mandatory breaths, and continuous spontaneous ventilation (CSV). All breaths are spontaneous. There are 5 basic ventilatory patterns: VC-CMV, VC-MMV, PC-IMV, PC-IMV, and PC-CSV. The combination VC-CSV is not possible because volume control implies machine cycling, and machine cycling makes every breath mandatory, not spontaneous. A 6th pattern, TC-IMV, is possible but rare. Within each ventilatory pattern there are several variations that can be distinguished by their targeting schemes. A targeting scheme is a description of how the ventilator achieves preset targets. A target is a predetermined goal of ventilator output. Examples of within-breath targets include inspiratory flow or pressure and rise time setpoint targeting, tidal volume dual targeting, and constant of proportionality between inspiratory pressure and patient effort servo targeting. Examples of between-breath targets and targeting schemes include average tidal volume for adaptive targeting, percent-minute ventilation for optimal targeting, and combined PC-IMV volume and frequency values describing a zone of comfort for intelligent targeting, e.g., SmartCare PS or IntelliVent ASV. The targeting scheme or combination of targeting schemes is what distinguishes one ventilatory pattern from another. There are 7 basic targeting schemes that comprise the wide variety seen in different modes of ventilation. Setpoint, a targeting scheme for which the operator sets all the parameters of the pressure waveform pressure control modes or volume and flow waveforms volume control modes. Dual, a targeting scheme that allows the ventilator to switch between volume control and pressure control during a single inspiration. Biovariable, a targeting scheme that allows the ventilator to automatically set the inspiratory pressure or tidal volume randomly to mimic the variability observed during normal breathing. Servo, a targeting scheme for which inspiratory pressure is proportional to inspiratory effort. Adaptive, a targeting scheme that allows the ventilator to automatically set one target, for example. Optimal, a targeting scheme that automatically adjusts the targets of the ventilatory pattern to either minimize or maximize some overall performance characteristic, for example, minimize the work rate done by the ventilatory pattern. Intelligent, a targeting scheme that uses artificial intelligence programs such as fuzzy logic, rule-based expert systems, and artificial neural networks. A mode of ventilation is classified according to its control variable, breath sequence, and targeting schemes. The preceding 9 maxims create a theoretical foundation for a taxonomy of mechanical ventilation. The taxonomy is based on these theoretical constructs and has 4 hierarchical levels: control variable, pressure or volume for the primary breath, breath sequence CMV, IMV or CSV, primary breath targeting scheme for CMV or CSV, secondary breath targeting scheme for IMV. The primary breath is either the only breath there is mandatory for CMV and spontaneous for CSV, or it is the mandatory breath in IMV. The targeting schemes can be represented by single, lowercase letters, set point equals S, dual equals D, servo equals R, biovariable equals B, adaptive equals A, optimal equals O, intelligent equals I. A tag is an abbreviation for a mode classification, such as PC-IMV, S. Compound tags are possible, for example, PC-IMV, OI. How modes are classified? Step 1. Identify the primary breath control variable. If inspiration starts with a preset inspiratory pressure, or if pressure is proportional to inspiratory effort, then the control variable is pressure. If inspiration starts with a preset tidal volume and inspiratory flow, then the control variable is volume. If neither is true, the control variable is time. Step 2. Identify the breath sequence. Determine whether trigger and cycle events are patient or machine determined. Then, use this information to determine the breath sequence. Step 3. Identify the targeting schemes for the primary breaths and, if applicable, secondary breaths. Example mode classification is given below. Mode name, /C volume control Covidian PB840. Inspiratory volume and flow are preset, so the control variable is volume. Every breath is volume cycled, which is a form of machine cycling. Any breath for which inspiration is machine cycled is classified as a mandatory breath. Hence, the breath sequence is continuous mandatory ventilation. The operator sets all the parameters of the volume and flow waveforms, so the targeting scheme is set point. Thus, the mode is classified as volume control continuous mandatory ventilation with set point targeting VC-MMV. Mode name, SIM volume control plus Covidian PB840. The operator sets the tidal volume, but not the inspiratory flow. Because setting volume alone, like setting flow alone, is a necessary but not sufficient criterion for volume control, the control variable is pressure. Spontaneous breaths are allowed between mandatory breaths, so the breath sequence is IMV. The ventilator adjusts inspiratory pressure between breaths to achieve an average preset tidal volume, so the targeting scheme is adaptive. The mode tag is PC-IMV. Descriptions of common modes. Mechanical ventilation machines are available with both invasive modes such as intubation and non-invasive modes such as BPAP. Invasive has to do with the insertion of medical devices or tubes internal to the patient, while non-invasive is completely external to the patient, as for example in using a tightly fitting mask or other device that covers the patient's nose and mouth. Assist mode, control mode, and assist control mode. A basic distinction in mechanical ventilation is whether each breath is initiated by the patient assist mode or by the machine control mode. Dynamic hybrids of the two assist control modes are also possible, and control mode without assist is now mostly obsolete. Airway pressure release ventilation. Airway pressure release ventilation is a time-cycled alternate between two levels of positive airway pressure, with the main time on the high level and a brief expiratory release to facilitate ventilation. Airway pressure release ventilation is usually utilized as a type of inverse ratio ventilation. The exhalation time TLO is shortened to usually less than 1 second to maintain alveoli inflation. In the basic sense, this is a continuous pressure with a brief release. APV currently the most efficient conventional mode for lung protective ventilation. Different perceptions of this mode may exist around the globe. While APV is common to users in North America, a very similar mode, biphasic positive airway pressure BiPAP, was introduced in Europe. The term APV has also been used in American journals where, from the ventilation characteristics, BiPAP would have been perfectly good terminology. But BiPAPTM is a trademark for a non-invasive ventilation mode in a specific ventilator Respironics Inc. Other manufacturers have followed with their own brand names Bilevel, Duopap, Bivent. Although similar in modality, these terms describe how a mode is intended to inflate the lung rather than defining the characteristics of synchronization or the way spontaneous breathing efforts are supported. Intermittent mandatory ventilation has not always had the synchronized feature, so the division of modes were understood to be synchronized vs. IMV not synchronized. Since the American Association for Respiratory Care established a nomenclature of mechanical ventilation, the synchronized part of the title has been dropped and now there is only IMV. Mandatory minute ventilation. Mandatory minute ventilation MMV allows spontaneous breathing with automatic adjustments of mandatory ventilation to meet the patient's preset minimum minute volume requirement. If the patient maintains the minute volume settings for VTXF, no mandatory breaths are delivered. If the patient's minute volume is insufficient, mandatory delivery of the preset tidal volume will occur until the minute volume is achieved. The method for monitoring whether or not the patient is meeting the required minute ventilation V differs by ventilator brand and model. MMV is an optimal mode for weaning in neonatal and pediatric populations and has been shown to reduce long-term complications related to mechanical ventilation. Pressure-regulated volume control. Pressure-regulated volume control is an IMV-based mode. Pressure-regulated volume control utilizes pressure-limited, volume-targeted, time-cycled breaths that can be either ventilator or patient-initiated. The peak inspiratory pressure delivered by the ventilator is varied on a breath-to-breathe basis to achieve a target tidal volume that is set by the clinician. For example, if a target tidal volume of 500 ml is set but the ventilator delivers 600 ml, the next breath will be delivered with a lower inspiratory pressure to achieve a lower tidal volume. Though PRVC is regarded as a hybrid mode because of its tidal volume VC settings and pressure-limiting PC settings, fundamentally PRVC is a pressure control mode with adaptive targeting. Continuous positive airway pressure. Continuous positive airway pressure CPAP is a non-invasive positive pressure mode of respiratory support. CPAP is a pressure applied at the end of exhalation to keep the alveoli open and not fully deflate. This mechanism for maintaining inflated alveoli helps increase partial pressure of oxygen in arterial blood. An appropriate increase in CPAP increases the PA-ATWO. Automatic positive airway pressure. Automatic positive airway pressure APAP is a form of CPAP that automatically tunes the amount of pressure delivered to the patient to the minimum required to maintain an unobstructed airway on a breath-by-breath basis by measuring the resistance in the patient's breathing. Bilevel positive airway pressure. Bilevel positive airway pressure BiPAP is a mode used during non-invasive ventilation NIV. First used in 1988 by Professor Benzer in Austria, it delivers a preset inspiratory positive airway pressure APAP and expiratory positive airway pressure APAP. BPAP can be described as a continuous positive airway pressure system with a time cycle change of the applied CPAP level. CPAP/APAP, BPAP, and other non-invasive ventilation modes have been shown to be effective management tools for chronic obstructive pulmonary disease, acute respiratory failure, sleep apnea, etc. Often BPAP is incorrectly referred to as BiPAP. BiPAP is the name of a portable ventilator manufactured by Respironics Corporation. It is just one of many ventilators that can deliver BPAP. Medical uses. BPAP has been shown to be useful in reducing mortality and reducing the need for endotracheal intubation when used in people with chronic obstructive pulmonary disease (COPD). High-frequency ventilation active. The term active refers to the ventilator's forced expiratory system. In a HFV scenario, the ventilator uses pressure to apply an inspiratory breath and then applies an opposite pressure to force an expiratory breath. In high-frequency oscillatory ventilation, sometimes abbreviated HFOV, the oscillation bellows and piston force positive pressure in and apply negative pressure to force an expiration. High-frequency ventilation passive. The term passive refers to the ventilator's non-forced expiratory system. In a HFVP scenario, the ventilator uses pressure to apply an inspiratory breath and then returns to atmospheric pressure to allow for a passive expiration. This is seen in high-frequency jet ventilation, sometimes abbreviated HFJV. Also categorized under high-frequency ventilation is high-frequency percussive ventilation, sometimes abbreviated HFPV. With HFPV, it utilizes an open circuit to deliver its subtotal volumes by way of the patient interface known as the facetron. Volume guarantee. Volume guarantee, an additional parameter available in many types of ventilators that allows the ventilator to change its inspiratory pressure setting to achieve a minimum tidal volume. This is utilized most often in neonatal patients who need a pressure-controlled mode with a consideration for volume control to minimize volatrauma. Spontaneous breathing and support settings. Positive and expiratory pressure. Positive and expiratory pressure PEEP is pressure applied upon expiration. PEEP is applied using either a valve that is connected to the expiratory port and set manually or a valve managed internally by a mechanical ventilator. PEEP is a pressure that an exhalation has to bypass, in effect causing alveoli to remain open and not fully deflate. This mechanism for maintaining inflated alveoli helps increase partial pressure of oxygen in arterial blood, and an increase in PEEP increases the paucity. Pressure support. Pressure support is a spontaneous mode of ventilation, also named pressure support ventilation (PSV). The patient initiates every breath, and the ventilator delivers support with the preset pressure value. With support from the ventilator, the patient also regulates their own respiratory rate and their tidal volume. In pressure support, the set inspiratory pressure support level is kept constant, and there is a decelerating flow. The patient triggers all breaths. If there is a change in the mechanical properties of the lung/thorax and patient effort, the delivered tidal volume will be affected. The user must then regulate the pressure support level to obtain desired ventilation. Pressure support improves oxygenation, ventilation, and decreases work of breathing. Also see adaptive support ventilation. Other ventilation modes and strategies. Negative pressure ventilation. Main article, negative pressure ventilator. Negative pressure ventilation stimulates or forces breathing by periodic application of partial vacuum air pressure reduced below ambient pressure, applied externally to the patient's torso, specifically chest and abdomen, to assist or force the chest to expand, expanding the lungs, resulting in voluntary or involuntary inhalation through the patient's airway. Various negative pressure ventilators and PV have been developed to serve this function, most famously the iron lung, a tank in which the patient lays, with only their head exposed to ambient air, while air pressure on the remainder of their body inside the tank. Though not in wide use today, NPV were the principal forms of hospital and long-term mechanical ventilation in the first half of the 20th century and remain in limited use today. Closed-loop systems. Adaptive support ventilation. Adaptive support ventilation (ASV) is the only commercially available mode that uses optimal targeting. This ventilation mode was invented and subsequently patented in 1991 by Tayrani. In this positive pressure mode of ventilation, the frequency and tidal volume of breaths of a patient on the ventilator are automatically adjusted and optimized to mimic natural breathing, stimulate spontaneous breathing, and reduce weaning time. In the ASV mode, every breath is synchronized with patient effort if such an effort exists, and otherwise full mechanical ventilation is provided to the patient. Automatic tube compensation. Automatic tube compensation (ATC) is the simplest example of a computer-controlled targeting system on a ventilator. It is a form of servo-targeting. The goal of ATC is to support the resistive work of breathing through the artificial airway. Neurally adjusted ventilatory assist. Neurally adjusted ventilatory assist NAVA is adjusted by a computer servo and is similar to ATC. In terms of patient ventilator synchrony, NAVA supports both resistive and elastic work of breathing in proportion to the patient's inspiratory effort. Proportional assist ventilation. Proportional assist ventilation (PAV) is another servo-targeting-based mode in which the ventilator guarantees the percentage of work regardless of changes in pulmonary compliance and resistance. The ventilator varies the tidal volume and pressure based on the patient's work of breathing. The amount it delivers is proportional to the percentage of assistance it is set to give. PAV, like NAVA, supports both restrictive and elastic work of breathing in proportion to the patient's inspiratory effort. Liquid ventilation. Liquid ventilation is a technique of mechanical ventilation in which the lungs are insufflated with an oxygenated perfluorochemical liquid rather than an oxygen-containing gas mixture. The use of perfluorochemicals, rather than nitrogen, as the inert carrier of oxygen and carbon dioxide offers a number of theoretical advantages for the treatment of acute lung injury, including reducing surface tension by maintaining a fluid interface with alveoli, opening of collapsed alveoli by hydraulic pressure with a lower risk of barotrauma, providing a reservoir in which oxygen and carbon dioxide can be exchanged with pulmonary capillary blood, functioning as a high-efficiency heat exchanger. Despite its theoretical advantages, efficacy studies have been disappointing, and the optimal clinical use of LV has yet to be defined. Total liquid ventilation. In total liquid ventilation (TLV), the entire lung is filled with an oxygenated PFC liquid, and a liquid tidal volume of PFC is actively pumped into and out of the lungs. Specialized apparatus is required to deliver and remove the relatively dense, viscous PFC tidal volumes and to extracorporeally oxygenate and remove carbon dioxide from the liquid. Partial liquid ventilation. In partial liquid ventilation (PLV), the lungs are slowly filled with a volume of PFC equivalent or close to the FRC during gas ventilation. The PFC within the lungs is oxygenated and carbon dioxide is removed by means of gas breaths cycling in the lungs by a conventional gas ventilator.